Peter, many know that Peter is a wonderful supporter and attender of pediatric grand rounds. You can usually find him sitting right up there in front. And so it's especially exciting to welcome him to the podium today. Something that many of you may not know is that before becoming a pediatrician, Peter spent a few years in business management after obtaining his in economics and business at Macalester College. He then obviously discovered his true calling as a pediatrician and headed to medical school here at the University of Minnesota. And he's been a gopher ever since. He completed his in pediatrics, his fellowship in general academic pediatrics, an MPH in maternal and child health, and a second fellowship, this time in health services research and policy, all here at the U of M. So as faculty in the Division of General Pediatrics and Adolescent Health, Peter wears many hats. He has been the medical director at St. Joseph's Home for Children in Minneapolis for almost 2 decades. He also provides care to adolescents and young adults at Hubert Humphrey Job Corps in St. Paul. And currently, Peter is a Robert Wood Johnson Foundation clinical scholar, and through this RWJ award, he participates in a leadership development program. And he co-leads a cool project called Dental Homes for Children with Special Healthcare Needs in Minnesota. Peter's research over the past decade has been supported by grants from the CDC. His work focuses on transition of adolescents with chronic conditions to adult-oriented care, including young people's self-management behaviors. And as you'll see from his presentation today, he is passionate about authentically involving those youth in this work. So Peter's and Melissa's presentation today, Can't You Just Grow Up? Yes, with your help, adolescents with chronic conditions can thrive. Please join me in welcoming Dr. Scal.
Thank you, Iris. That was very nice. Yes, and I do want to talk about my passion. What's been driving me for the last 20 years in my work in adolescent health is that I really believe that it's not enough that we as pediatricians seek to just treat the ailments of children. I think that really what we want to be doing is using our treatments, our programs, and our policies to really emphasize that is to see that this generation of children that we are caring for now becomes the next generation of young adults who are the healthiest generation until the next one replaces them. So rather than focusing simply on our work, and it's not simply, rather than focusing on our work of treating, that's seeing how we can move them and have them thriving as young adults. It sets the goal out there, and it actually resonates with them when they talk about the future, and that's when I think you've got them. So that's what we're going to be talking about today. Let's see. Here we go. Of course, we have no conflicts of interest to declare. No one funds this, because I think that this is one of those topics that's relevant to really everyone in this room. I feel like we need to stop before I dig in with my stories and have you all kind of put somebody in your head, and particularly an adolescent with a chronic illness that you've seen recently. So I'm going to ask you to spend a minute thinking about a recent or particularly memorable adolescent or young adult that you provided care for in the last while. Memorable because of the challenge, or memorable because of the reward, or because it freaked you out, or it was really fun. So go ahead and take 30 seconds, put someone in your head, and then go ahead and share something about that person with someone close to you, close by. And some people are sitting far in the corner, as they usually do, but I bet there's somebody that you can share with. So you can't do think, pair, share, you move in this case. So please share it. It's helpful. I'm sorry, I missed it.
People are.
Yeah, yeah. All right. Well, I hear chatter still going. Thank you for that. I hope it's about the topic that I suggested. And I'd love a couple of your experiences. Can someone volunteer to tell a short, someone, of course, confidentially, a situation that you were with an adolescent in chronic illness that challenged you, rewarded you, or just is a great story? I got but I want to hear yours. No one had one? Okay, go ahead. Thank you. Yeah, so mental health is the elephant in the room that we're not prepared for. And that goes with many other chronic illnesses, as we can talk about. And it's frightening. I mean, it's real. It's a healthy person becoming unhealthy. Or other situations. All right, I'll be embarrassing and I'll share my own family story. As a pediatrician, I raised two boys, and one of them talking about how much his bottom hurt, and he kept on hurting, and I said, call your doctor, go to your doctor. I'm trying to model this transition stuff. And finally on a Saturday night, he came to me and said, it really hurts. And, two choices. I can look at it, or we can go to the emergency department. And he chose, luckily, going to the emergency department, your emergency department, where it turned out to be a significant issue for him. He had Crohn's disease and had these anal fistula that were bothering him for years. But as a pediatrician, I didn't respond appropriately, I guess. Anyway, I think, we all have stories about chronic illness, and it doesn't matter which specialty you're in, right? So I can even think of kids I've seen in my homeless shelter who are graduates of the NICU. One of them even said, yeah, look, and he pulled up his shirt to show the scars. He goes, I can't throw up because they did a surgery on me. And, a young adult who we worked through, how do you actually explain that more appropriately to a doctor in the future, and what your needs are. But, they're out there. I see them every day at Job Corps and at St. Joseph's Home for Children. I see kids with heart transplants. I see kids with Crohn's disease, epilepsy. This was all just in the past week. Significant psychosis. And they're really not prepared to talk about their chronic illness and how to engage us as health providers. And some of those conditions I really am not prepared any longer, or was ever prepared to deal with as a pediatrician, as a general pediatrician. So this is about being humble, recognizing that we don't have all the answers, but there actually is a partner in the room with us that can help us through that, and we can help them at the same time. So partnering with young people, I think, is one of the critical messages here. I want to go through our objectives real quickly, and then move on to the next one. All right. So I really want to help infuse this notion of a psychosocial developmental model and its interaction with chronic illness and the demands that that places on young people, so that when you start to see kids and they're doing great things because they're now raising money for the Epilepsy Foundation, and you're just like, wow, this is a superstar, you're realizing that they're expressing their developmental needs in a way, or their medications is probably the one that we pull our hair out most about, is they're expressing their developmental needs in some way, and maybe a misguided way. And then I want to introduce to you this model of a developmentally informed motivational approach that I've been working with for about 10 years, actually 12 years. It started in a project I did in rheumatology I'll tell you about, and it really has grown to something that I think is now in a place where we can start to use it in everyday clinical practice, in research, and other areas. And then I want to leave you, especially the residents, with the feeling that there's something that you can do at every encounter with that adolescent that will help them to move along in taking responsibility for managing their health care, not taking it all right now, but start them on the path. And these are simple words you can use to start the conversations and keep them moving forward. So with that, I'd like to introduce a guest speaker that I'm really excited to present to you. Melissa Engel is a graduate student in psychology at the Institute of Child Development across the street. She came to my projects via Andy Barnes, who said, wow, she's got some really interesting ideas about chronic illness, and I think that you guys could really do some good research. So for the last year, Melissa's been working on my projects, particularly the epilepsy project, and along the way, she came to me and said, you know, I have a letter I wrote, and I'm wondering if you might read it and see what you think. And read it, and I was just struck, and said, this to get out, and we need to share this. And so Melissa went ahead and submitted the letter to her doctor, to Journal of Adolescent Health, which promptly accepted it and just published it this month in their both online and print version, a letter to my doctor. So Melissa will read that first, and then come back later in our presentation and talk about some of her research as well. Come on up.
Can you hear me? All right. To my doctor. Tears rolled down my cheeks as I left your office last week, and I have been overcome with emotion since. I cannot quite pinpoint the origin of these tears. This was just a typical doctor's appointment with you. But you are definitely not a typical doctor. When I first met you, about a year after being diagnosed with type 1 diabetes, I could tell you are no ordinary physician. First, you had me add your cell phone number to my contacts. You then proceeded to take a photo of my molluscum on your iPhone so that you could easily reference it later. I do not know of another physician that links his or her office voicemail to his cell phone and texts patients thoughtful responses within minutes at all hours, including on weekends and holidays. Time and time again, you make me feel like I am your only patient. Clearly, I know this is not true. You are the director of one of the country's most prominent diabetes centers and are often referred to as a leading world authority on diabetes. You are constantly traveling the globe for research and teaching purposes, and my appointments constantly get canceled because of this. Yet you still give me boundless attention. From casually mentioning that you discussed me with a researcher when you met for lunch last week in Paris, to putting me in touch with geneticists in California, to reciting my complex medical history to me like it is your own daughter's, to spending an hour in my exam room at each appointment, it is evident that you truly care. I have always respected you greatly, but it is only recently that I realized how loving and compassionate you truly are. This is a bit ironic, as I would not describe you as warm and fuzzy. In fact, your remarks that stand out most are quite harsh and depressing. You are very strange. We have known this for a long time. I do not think going away to school in another part of the country is a wise idea. Very interesting case study. When you're a patient, being very interesting is not a good thing. Unfortunately, we still have so much to learn, there are many conditions that we do not currently have treatment for. You are so vigilant about controlling your blood sugar. I know you say you feel better when it's lower, you like being in control, and you want to avoid later complications. But what happens when you don't wake up one morning from a low blood sugar? At that point, there won't be time for later complications. I believe it was your talk about mindfulness that set off my tears last week. Acknowledging the limitations of Western medicine, admitting that our traditional notion of science cannot cure me, but believing that I can keep striving to live the highest quality of life that I can. In this moment, I was overcome with your humility and humanity. In When Breath Becomes Air, Paul Kalanithi speaks of learning to treat his paperwork as patients and not vice versa. You have gone above and beyond this, treating me not only as a patient, but as a person. You listen empathetically. I cannot tell you how important this is. When struggling with enormous autoimmune complexities, there is nothing worse than feeling alone. There is nothing better than being listened to, heard, validated. You know I am suffering. You acknowledge my difficulties. You convey that you are sorry, that you wish things were better. You treat me as a whole person. You're an endocrinologist, and your job is to treat my type 1 diabetes. But you spend more time thinking critically about my stomach problems than any gastroenterologist ever has, find flaws in tests ordered by other departments, and regularly address my mental health. When asked for my primary care physician, it is your name that I unconsciously write down. Through all this and more, you bring me immense hope. In such difficult times, hope is everything. I hate to say it, but you have not treated me with any medication other than insulin that has alleviated any of my autoimmune issues. While I feel like my physical health is deteriorating, the mental strength you provide me is invaluable. Our relationship embodies the power of the doctor-patient connection, and I certainly hope that stories like mine can help shape the future of clinical care. After grappling with the source of my tears, I have concluded that, above all else, they were tears of gratitude. Gratitude for having a doctor who is not simply a physician, but a caring, listening, contemplative human being, a true healer. I certainly hope that I do feel better soon, but either way, I look forward to future research collaborations. I aim to treat other chronically ill adolescents with the values that you have instilled within me. Perhaps it is fitting that the only photo we have together is from the Juvenile Diabetes Research Foundation Gala. Rather than your typical white coat and my sweaty workout clothes, we are sporting elegant attire. We are dressed up and smiling big on a Saturday night, not as doctor and patient, but as equals, as two compassionate souls who care about each other deeply. Thank you from the bottom of my heart.
So hard to follow that. That was really wonderful. Thank you for sharing it with everyone. I know you had to think about whether it made sense to read it out loud. Personally, it's now being read by thousands of people around the world through the Journal of Adolescent Health, and I know that you've given us a gift. So thank you. The clicker. All right, so that was what was supposed to be up there. All right. I can't start talking about transition to adulthood and transition to adult health care here at the University of Minnesota without recognizing that this was a place of leadership a long time ago in this field. In fact, in 1984, Surgeon General Everett Koop came to Wayzata with faculty members from here and parents from around the state to talk about this issue of what are we going to do as our young people with chronic illness and disability are growing up. It turns out, interestingly, that Dr. Koop was a pediatric surgeon. I don't know if you all knew that. I didn't until I started reading about him. But he was passionate about this issue because many of his kids were growing up, his patients were growing up and continuing to seek his care well into adulthood, and he felt that was just more than he could handle in addition to being the Surgeon General. And I think what strikes me about what he has to say is that it seems to be as true now as it was when he said it nearly 30 years ago. I know that one of the persistent problems of American medicine is the difficulty of transition between pediatric and adult care. I wish we had solved this a long time ago, and I'm sure he would have wished that as well, but we haven't yet. In fact, we've had little progress, and I'm going to switch there. We've had little progress on this issue. In fact, in 2002, we started doing population-based measures on how well are our systems working to move young people to adult health systems. And so we did it was a parent survey, and the results were really discouraging. So the Maternal Child Health Bureau said, well, we've got to do this again. Maybe we did something wrong. And 3 years later, same results. Less than half of young people with chronic illness had spoken to their doctor about moving on into adult health care, about taking care of their own health, about getting health insurance. So 2005, then 2007, again repeated, and there's been a series of these where up and down, it seems like there's a little progress, and then there's nothing. And then the most recent survey in 2016-17 now shows that about 18% of young people have met all of the criteria that Maternal Child Health Bureau set for making the proper transition to adult care. They haven't spoken to their doctor about insurance. They haven't spoken about who they're going to see when they age out of their system. So, it turns out that this is a really complex issue, and as a researcher, I kind of love that. There's something here in every part of our medical system that needs to be addressed, and that's what makes it so hard. Early on, when I was doing my health services research, what we recognized was that about 30% of adolescents, maybe 25% of young adults with diabetes were uninsured. Think about that. 25% of people who need daily treatment didn't have insurance to pay for that. And then along came Affordable Care Act, and that was pretty much taken care of. Yet we knew, and we wrote about this, that this was not going to be the solution that many people were hopeful about for a couple of reasons. One was adult doctors aren't prepared for young adults with chronic illness. That's not kind of how they trained. The other was that young people weren't ready to move on and take that responsibility and move forward. And we had an inkling that what did happen was going to happen, and that was that insurance said, well, yes, we want all those people on our rolls for population-based insurance pricing, but we don't want to give them the kind of services that they need. And they've really reduced ability of young people to get medical care services, and that's become a real problem for people with chronic illness and disability. Thinking about, again, my own family, my son gets an infusion every 8 weeks that is billed out at $40,000. So hospital doesn't get that much, but it would be quite something if he was turned down for that medication and we had to work 2 jobs. So there is no simple solution. And the way I've approached this is to really step back and look, and I think this is one of the things that I'd like you to put into your head, that if we try to address this issue at one level, if we try just to fix our interactions with young people or help them, they're going to bump up against the next level of problems. Maybe the parents who aren't going to let go, or the parents who prematurely gave them responsibility, or the teacher who doesn't believe them, or the institution that won't let them come back to their clinic because they turned 18, or that beds them with a 70-year-old with pneumonia and makes it really hard for them to feel they're getting the care they want. And those issues like insurance coverage, and is it appropriate for their needs? So we want to think about how each of these pieces interact, and can we start to inform these interactions and work at the intersections? Can we work to make this connection stronger rather than just try and prepare them to overcome it? So the ecosystem model of health and well-being would be one way. Then I think, we can't be pediatricians and thinking about child development without adding to it a life course model. So life course adds to this ecosystem model the fact that things change and all the influences on people change as time goes by and as people get older. So time goes by is different than getting older, right? So time goes by is the notion that our treatment of today is not what people 10 years ago got. And I think I'm seeing Bryson smiling because so many of the kids with arthritis now look back and say, what do you mean you got a joint replacement surgery? I've never heard of that before. And yet 10 years ago, that was the norm for a young adult with significant rheumatologic condition. So point in time is one issue we have to take care of. The other is that kids have different influences. And this is really important to be thinking about. What is it that's changing that in the child's development or this adolescent's development that might be influencing why suddenly they're not taking their medications anymore or they're not doing their treatments anymore. Right, suddenly thinking about, yes, now they're listening to their friends and they want to go out at night, or they don't want to take their methotrexate because they want to go and drink alcohol. There are lots of things going on in their lives that change, and sometimes we need to put our developmental lens on to think about what that is. So consider that. Think, where are they at? And ask them what's going on. Then the third one that I'd like to bring to mind is one that we'll get into in more detail as we go on. But it's a model of really how do we interact with people on a one-to-one basis or at a program level to influence behavior change. I think this is critical. We've probably all grown up now to learn motivational interviewing. And that's one way of imposing our perspective on other people. It can be an effective communication tool. But I think we've got to take the next step and move to a little bit more adolescent-centered, developmentally oriented approach. And I think I can explain how we can do that in this hour. And you can start when you go back to clinic. All right. A lot of my ideas have been informed by not only the work of other people, but the work that I've done. So I get the question and choose to pursue it. And so I've titled this section of the talk, Getting to Yes, because Yes is the name of our current project, Youth, Epilepsy, and Successful Self-Management. That's Yes. And to get there, we made a few steps. Starting about 13 years ago, we went and worked with Rich Vey, and Bryce was just coming on board, I think, at the time, to build a program for youth with rheumatologic conditions, with arthritis. And that was an exciting time for me, getting out from behind these data sets with 100,000 people, but only 10 kids with arthritis in them. So now we decided to go out and build something to do something about the issue. And we built Room to Grow, named by the young people. It was a rudimentary website that kids could get onto and kind of explore the social experience with other kids who had arthritis. And, we knew at the time that we weren't willing to go down the path that they wanted. We did our own thing anyway, in spite of it, in spite of what they were telling us. And that was that they wanted more interaction, right? So we knew that we could give them information, we could maybe help motivate them a little bit, but they wanted to hear from each other. We tried to substitute, it didn't work. They told us that very clearly. We want more of the real-time interaction between the kids. Well, in that time, 13 years ago, that was a little more difficult to do. Now it's, we're way behind them. So from Room to Grow, though, what I started to understand was that we needed better measurement and understanding of a model of what we're trying to accomplish here. We're not just trying to get them to adhere to medications. We're really trying to move them on to see the world ahead of them and to use that as a motivator to do the things they need to do. So what we designed was actually going back to a survey study, and that was my path. My path was a survey study funded by CDC of youth with physical disabilities. So these were cognitively capable young people with physical disabilities, muscular dystrophy, cerebral palsy, spina bifida, and then quite a few with kind of non-categorized physical disability using wheelchairs. And these young people responded to surveys every 6 months for 5 rounds of surveys. And remarkable. I mean, these were long, tedious surveys. They had measures that repeated themselves many times, and yet we retained 80% of the kids in this survey over the time, which was really, I think, a tribute to Renee Sieving and her group of Prevention Research Center researchers who just knew how to get the kids to answer again. So what we did was, in this study, we really embedded our model, or our hypothesized model of motivation, and we tried to see whether it made sense, whether we could measure it, and whether the associations were there, both at a cross-section at one time, but whether they persisted over time. And with that, we then went on to Yes Project. One of the things that struck me in Room to Grow was this statement, and it's been kind of my go-to statement now for 13 years. When we asked our advisory group of adolescents, 18-year-olds with arthritis, whether they would want to do some of the things that we had kind of put in our grant, like did they want to learn how to talk to their doctor? Did they want to know side effects of their medications? And they kind of glassy-eyed, and said, yeah. And it was really unenthusiastic, and you knew it wasn't there. And then finally, one of the young men spoke up, and I thought this was great. He said, I want to deal with arthritis and the way it bothers me. It's not going to go away, I know that. But if you can help me make it less of a bother in my life, then I'll participate as an advisor on your group. And then the rest of the crowd joined in, and Jake is a leader among that group, but he really did kind of get them excited to join us and change the way we were thinking. So we really moved to this notion of what did we want or what did they want, and we got to bring them together. So make it less of a bother. The example he used was, how do I talk to, I'll learn about my medications if it helps me to talk to my boss at Valley Fair, because I just got a job as a lifeguard, but I can't be out in the sun because of my medications, and I can't explain to them why I can't be out in the sun because I don't really understand it. So he wants to learn it for a reason, and that became really what we learned. If we can figure out what's going to motivate them, we could use that as our lever. So we built Room to Grow. It was flashy, and the kids said, it's okay. Then when we went to My Path, we used this model, and I want to explain this model a little bit. I know clinicians don't love hearing about theoretical models. What I want you to take away from this is that it has practical implications from when you walk out the door. This is a theory called self-determination theory from psychologists in Rochester, Deci and Ryan. They came up with this notion in the 60s, and it's grown into this really one of the most commonly cited behavioral theories now in the world. And it's used in exercise and sport. It's used actually very little in medicine, some in adult medicine, but more in exercise and nutrition, sport, education, and in adult obesity prevention, that sort of stuff. But we've been using it, and here's what it says. It says that there's a belief in self-determination theory that people will make choices that move them to a healthy place. It's their perception that they're moving to a healthy place. So sometimes we can say, well, that's not getting you there, but it's really the belief of self-determination theory that that behavior is doing something that the person believes is getting them to a healthy place. So their behaviors are getting them to be healthy, and their behaviors are motivated by, kind of carrots and sticks. So an intrinsic motivator would be something that they really like to do. So I love eating great food, so I'm, going to eat it and not care about my health, but I'm going to eat really healthfully because I love the taste of it. On the other hand, you've got this extrinsic motivation. This is the classic. My mother-in-law, a pediatrician from long ago, who used to use her long finger and bony finger and say, "You got to do this," and she was right, but it didn't make people do what she wanted them to do. So extrinsic motivation we know is effective. It's as effective as long as you continue to apply the stimulus and the power of that stimulus decreases and you require more and more of that stimulus to get the same behavior. So extrinsic motivation, sure, you can use it, but it's not going to be very effective. And extrinsic motivation, this is why I love theories, because they explain common sense. And the theory then says there's other kinds of motivation as well, interjected, where you're doing it maybe to make other people happy, but not because there's a threat, identified because you understand that this might be somehow good for you, but you're not convinced that you really want to do it, so you're on the fence there. What this theory says now is that people will enact behaviors and they will sustain them when the motivation is on the intrinsic side. That makes sense. The other thing it says is that you can have both intrinsic and extrinsic motivators for the same behavior. Kids acknowledge that. Yeah, I'm doing it because my parents will take my Xbox away if I don't, and because I kind of like doing it, but I don't tell them. So there can be both, but the behaviors will be enacted with the most vigor when the ratio or the combination of intrinsic and extrinsic motivators highly favors this side. So high intrinsic, low extrinsic. And I'll show you that in our data, we found that to be true, that high intrinsic, low extrinsic beats high of both, right? So when you're doing it solely because you believe in it, and it's giving you some value, it's better than a combined approach. So that's the theory. And it gives us, actually, the next part is, it gives us a way to act as clinicians, right? And that's to say, to get to these motivational types that we want, the intrinsic motivations, we need to support some basic needs of young people. The need to feel autonomous, that you're making a choice. The need to feel that when you're doing the behavior and the outcome will meet your social needs. Like, I need to let my friends know that I have arthritis, because when we go to the mall and I say that I got to sit down, they'll accept that when they know I have arthritis, but they won't accept it when they think that I'm lazy. So if I can do something about it and keep my social position and get my social needs met, I'll do it. And if I feel I'm competent. Now, competence is a ladder, right? So we can not. If you give somebody an expectation to be at the top of the ladder and do the hardest thing first, they're going to look at that and probably not be very motivated to do it. But if you say, well, let's make the first step and move them up as they become competent, you can keep on increasing their search or quest for competence and not bore them and move them into this type. So clinically, if we find ways to support autonomy, relatedness, and competence, we'll move people into these preferred motivational types. And again, our data from that longitudinal study and a survey of youth with epilepsy show this model to be, the data are consistent with this model. Now, we haven't tried this experimentally, and that's what we need to do next. So in our data of youth with physical disabilities, we found that we tested whether autonomous motivation or controlled motivation were associated with ability to manage their own healthcare and reduce their unmet needs. And we found that to be true. So people who were autonomously motivated had fewer unmet needs. We also found that longitudinally, the combination of low controlled motivation and high autonomous motivation, which we call mature, right here, had the best outcomes, better than maturing. These are names we just made up, and you can come up with your own. Better than maturing, so high levels of both types of motivation. Mature beats maturing. Mature beats transitioning, sort of mid-road of both of them, and it meets, beats obviously this one, the low motivational type. So they're not motivated, or they have low motivations. So this was really encouraging, and that led us to go back to intervention development. And so this model then holds true, at least from our perspective in a survey validation method. And that took us to YES. So YES is now our latest intervention. It's been a 5-year project where we've gone through the process of focus groups, surveys, and now we're wrapping up our pilot intervention with 120 youth to see whether we're able to impact their autonomy, competence, and relatedness, move them to higher stages of intrinsic motivation, and reap the rewards of them being engaged in managing their healthcare without actually having tried to teach them about the things they need to do. That's our goal, that's our hope, and we'll get our results soon. Next week is the last week kids are on the website, and we'll start look at data from there. Along the way, I said we did some survey research, and what I'd like to do is have Melissa go ahead and present some of the work that she did that kind of takes a step back and says, what are we trying to get to? What's the result that we're trying to achieve? And I know that all of the folks in the epilepsy world are telling me, Peter, we want to hear about fewer seizures. We want to hear about better adherence to medications and fewer emergency department visits. Okay, great. We all want that, but we also want more than that. And so that's what Melissa will present now.
All right, so switching gears from patient to researcher, again, my name is Melissa, and I'm a PhD student in clinical child psychology at the Institute of Child Development. So from a research perspective, I'm interested in what enables young people with chronic conditions to thrive despite their high medical risk. And while perusing the medical literature, I became really struck by the narrow conceptualization of quality of life in medicine. This really contrasts with ideas in psychology in which the concept of well-being is seen more holistically across several domains of life. And the opportunity to explore these constructs came about through a data set with Dr. Scal, which included validated measures of both health-related quality of life and overall well-being in a sample of adolescents and young adults with epilepsy. The differences between the concepts of health, quality of life, and well-being are quite pronounced. And to illustrate, here are a few examples from our questionnaires. So the measures we examined were the Quality of Life in Epilepsy Inventory and the EPIC measure of adolescent well-being. Quality of life items asked adolescents, how much do your school or work limitations bother you? What about your social limitations? How much do the effects of your medications bother you? In contrast, well-being items asked adolescents to indicate to what extent statements like these describe them. I love life. There are people in my life who really care about me. I am optimistic about my future. So health-related quality of life is increasingly common in medicine. However, as you may notice, it's quite illness-specific and negatively valenced. In contrast, well-being measures are rare in medicine, at least currently, but they address more global psychological health and are positively valenced. So they're both patient-reported outcomes, but otherwise they're quite different. From these ideas, I propose the following research questions. Is a greater medical risk associated with poor quality of life and well-being in adolescents with epilepsy, as the traditional medical model would predict? And do positive intrinsic factors influence the relationship between medical risk and outcome? So we created a risk gradient consisting of seizure frequency, number of anti-epileptic medications, and number of other medical conditions, and looked at the correlations between both medical risk and epilepsy-specific quality of life, as well as medical risk and overall well-being. We found the expected relationship between greater medical risk and poorer quality of life. However, this relationship did not hold for well-being. As you can see, on the x-axis is medical risk score, and on the y-axis is patient-reported outcome. So above is quality of life, and below is well-being. Together, these findings suggest that health-related quality of life and psychological well-being are qualitatively distinct constructs in adolescents and young adults with epilepsy. While health-related quality of life is consistent with the traditional medical model, well-being is perhaps not. Next, we wanted to understand whether modifiable intrinsic factors might be able to reduce the impact of risk on quality of life. A consistent, strong factor that seems to moderate risk across other contexts is self-efficacy. We chose to examine self-management self-efficacy, the belief that adolescents, that their own actions can impact their health. We examined whether the self-management self-efficacy moderated the relationship between risk and quality of life, and whether this held true across all levels of risk. So we established 5 levels of risk from lowest to highest, and using hierarchical linear regression, estimated what the relationship between self-management, self-efficacy, and quality of life would look like at each level of risk. This was a way to estimate what we might find if we were able to experimentally increase each individual's confidence in managing their condition. So this slide displays the results. The x-axis displays self-management, self-efficacy. Each color represents a different level of risk, 1 being the lowest risk and 5 being the highest risk. And the y-axis displays the predicted quality of life score. So for the majority of youth, increased confidence in their ability to manage their health was associated with significantly higher quality of life. For youth at the very highest level of risk, this relationship did not hold, suggesting that self-management, self-efficacy in it of itself might not be enough for them to overcome their vast medical complexities. However, for most youth, self-management, self-efficacy represents an important intrinsic factor that may be amenable to intervention. And there's a lot here that we don't have time to discuss, but we just submitted this manuscript a few days ago, and I'm happy to discuss more later. But there are a few key things I want you to take away. So, greater risk was associated with poor quality of life, but did not correlate with overall well-being. This suggests that risk, as we see it in medicine, does not predict overall well-being. And second, self-management, self-efficacy, the belief that young people can manage their disease, may help reduce the negative impact of medical risk and improve quality of life. Therefore, promoting the confidence of young people to manage their medical condition is an important target. And I interpret this all to suggest that cultivating psychological strengths in young people, as opposed to solely addressing their medical problems, may be a promising intervention target when treating adolescents and young adults with epilepsy, or for any condition. So this is just as relevant to the cardiologist or rheumatologist in this room as it is to the psychology graduate student. So thank you.
That was great. Thank you very much. So that was way better than I could have presented it. So thank you. So really, our data set is rich in these kinds of measures. We actually had 4 different well-being and quality of life measures because we wanted to examine this really robustly. And this is an important finding that how is it that this young person says they're doing great, and by any account from me medically, they're having a tough time. And it's like, it's because they have a different view of their life, and we have to learn how to see that, either by using a tool or by asking those questions. And I think we can, and I find it to be really exciting when I ask them to have that conversation with me. They kind of start first and then come to the table, and it's enjoyable. So what I want to do is now just move us into the last section, quickly tell you about what YES is, and then the clinical pearls. So what we did was with YES was we we created this website where, again, like in the Room to Grow, we created a secure, private place where young people with epilepsy could log in. It's a HIPAA-compliant server with all the protections that costs if I was in public health, I might not have to pay for all that, interestingly. But I'm glad we do, because it gives the parents the feeling of security that their kid is on a website from the University of Minnesota that is not going to be where they get into trouble. What we wanted to do was give them the chance to explore on their own, right? So young people may have a question that wasn't answered in clinic last week, or may not be a clinic visit for quite a while. So we wanted them to say, oh, I'm interested in this, and I'm going to go check it out. Now, we know from Room to Grow that they don't check out very far into the depths of all this unless they're kind of prodded to. So what we did was we created lots of ways to kind of prompt them to go down that path. Like, what advice would you give your friend? Check this piece out, or something of that sort. We always gave advice with options. Every time there was a solution to a problem proposed by a kid, or posed by a kid, there would be a menu of choices that we as medical providers felt was acceptable. We would never put up the things that some of them said that weren't, but we could say, that's a really important way to look at it. I see it differently. And we give them the language to use when they're coming back to the providers. There's an Ask the Nurse that provides accurate medical information. There's Ask the Peers, getting the social experience in there. There's parts about keeping track of your seizures and all that stuff. It's all in there, and we'll get a sense of how much they used it shortly. But what it's taught me, as we created all these scenarios, was that I can do a lot of this face-to-face with kids. Even though online I'll see a lot more kids than I would in clinic, I can still do it in clinic. I think every time I see a young person, I look for that opportunity. It came up yesterday in clinic. A resident was with me, and simple questions like, wow, how is that going to change when you exit foster care? So nearly 18-year-old was about to graduate and had no idea where she was going to get her care, and we were able to start the conversation and go through it. Another young man there, 18-year-old, I'm doing great, I'm healthy, and all this. And I said, ever have any surgeries? Oh yeah, when I was a baby, I had this surgery. My veins were going the wrong way, and so they had to do heart surgery right away when I was a baby. And so, how are you doing now? Good, fine. Yeah, I had a redo last year. And he said, so now they said I'm good for 50 years. And it's like, good idea. Anything else you need to be careful of? Well, I don't think so. It's like, oh, great. Now let's have a conversation about this. And so, not asking him to recite it all and expecting that he will, but moving him forward. We set up a plan in that case where he was going to call his mom and say, hey, what's the name of that thing that I have? And that was fixed. And so we're going to start simple and start writing them down. But we can ask them, how does this impact you at school? Like, what's your epilepsy like at school? Do you have to take your meds there at school? And like, oh, no, I don't, and then start a conversation. What's it like when you have to tell your friends that you've got epilepsy? Boy, they'll actually kind of really engage in that conversation. So these are the things that are getting them to talk about it, to get them. We don't need to know the answers. I mean, it's not for me to write in the chart. I'm not taking a deposition here, right? What we're asking them to do is think about what's going on in their life. As a caring adult, we think it's important, and they may deny it. We're not going to push them into it, but it's what you can do every day, and that's what I'm doing every day in clinic with my adolescents. And then you can formalize it, and this is actually something we put together 15 years ago, is really to use your heads. Use the home, education, employment in this case, and those questions that you're supposed to ask when you're getting to know a young person. What's it like to have epilepsy at home? Do your siblings mind that you get all this attention, or does it bother them? Do you get a chance to get away from your family when you're asking the H questions? What about education? What does this mean for you job-wise? Like, have you thought about that at all? I'm not going to get into all the counseling about it, but I can bring the topic up. And with the thing I'm already doing, which was heads, I realize that we are At the end of the time, we want to have a few minutes for discussion or questions. Thank you, and leave you with this beautiful portrait by a 14-year-old. I'm always amazed at the kinds of things they do. This was an exhibit that I went to at National Portrait Gallery, and maybe we could do something like this here to celebrate our young people. So thank you very much. So we're happy to take questions. If they're specific to one of us or you'd like to have both of us answer, please let us know. And just while we're getting ready here, so first year medical student, there was a lecturer that would hand out dollar bills to people who asked and answered questions. I thought that was a little crude. But instead I have rewards. Have some, because thinking putty is something we can all use. And so it appears that Joe will get the first thinking putty.
I'm okay. So you've talked a lot about transitions. What does a successful transition look like from the perspective of the internist or the family practitioner receiving the patient? This is all our side of the fence.
Absolutely. So that's a great question, and we only know what we hear in surveys, and I don't always believe that to be actually what people want. They expressed it somehow, but what they're saying is they want young people to be able to talk to them. They don't want the parents in the room, or they want to be prepared on how to deal with the parents. They want young people to know those things that, are actually in their record. They want to know their medications, what the history has been of their disease. And they want them to speak up, right? I mean, there are the kids in the rheumatology clinic who said their adult docs never listened to them. Don't examine my hips. It's never been in my hips, sometimes the kids need to learn how to talk to the docs, and the docs need to know also how to listen. Yep. So I'll get that. And Sue gets the next one.
So thank you, Peter, for putting a framework on all this. I think a special challenge that you didn't really address, but I see it all the time myself, is the intellectually disabled young person who needs that transition just as much, who needs compassionate care from an adult provider who's not prepared for it, and who really won't be able to speak for themselves. And how do we facilitate that exchange? Because that's just as critical.
Yep, absolutely. So there's this range, right? And in epilepsy has been a perfect example for me. So epilepsy, about half of the people, young people with epilepsy have a significant cognitive impairment. The other half, it's probably drug-induced impairments, actually, so we need to address this issue across all children, not just specifically to individual groups. How do we do it? The same way, I think. What's home going to be like for this young person when they turn 18? Home, they're going to have a home, right? That's not changed. What is their opportunity for education and employment going to be? Can we still talk about that? And if we normalize it, actually, I think in most cases, parents will tell us which ones are the important ones and which ones they don't believe are important. Now, it doesn't mean there's an answer at the other end, right? I mean, that's the critical piece. We don't have the answers, and I wish we did. I mean, as I said, it's been 30 years that we've been pushing on this thing, and it's really not changing. In fact, it may even be getting worse. What are we going to do about it? And I think we do have to start to ask that question. If no one's building what they need, does somebody need to step to the plate and do it? The kinds of group homes and the kinds of training for physicians that are going to be there. So workforce is an important part. Absolutely. Thank you. Here, I really want to get rid of these. I have so many. Any other questions? We're happy to take more. If not, then we'll be here afterwards. Please, I so appreciate that you were here, and I'm open to any conversations. We have a lot of experience in our group, both doing the research and both in the clinical services. We're happy to talk to you. Melissa, an awesome resource, both as a researcher and as a person who's lived through much of this, and I think she is happy to share that. I mean, she's written it and published it, so it seems that way. If you'd like a copy of her letter to the doctor, it's in the back table. Thank you very much. I have. Who wants some?
You have been disconnected from the meeting.